I'm Dr. Rashmi Halker Singh. I'm the Deputy Editor of Headache. It's my absolute pleasure today to be joined by Dr. Jennifer Robblee, who is the first author of the 2025 guideline update to acute treatment of migraine for adults in the ER, the American Headache Society Evidence Assessment of Parenteral Pharmacotherapies. Welcome, Dr. Robblee. I'm so excited to speak to you about this.
Thank you so much for having me here. I'm really excited to be speaking about it.
So first of all, can you share with our audience what prompted AHS to update the ER treatment guidelines for 2025 and what problems were you all hoping to address?
I mean, first off, we know that headache, particularly migraine, still leads to patients going to the emergency room way too often. There's about 3.5 million headache visits a year, and at least a quarter of those, probably more, are migraine. Over a third of them aren't getting headache freedom. There's still massive variability in how we treat patients. I mean, most of the time they come back and tell me, I had a migraine cocktail. Do you know what was in it? Medication. Good to know. We still know that opioids are getting used. The rate of how often they're getting used has at least decreased, but they are still getting used as, a first-line treatment or a pretty early in the selection treatment. So there's still lots of room to move. Plus, we knew there was a lot of new studies. We know that there is now a lot of data on nerve blocks, which had not been looked at into the 2016 study. So lots of things that we could really address and try to update. The other impetus was that the guideline committee likes to have their guidelines updated every 5 years, and we're past that 5-year date, so it was time to do it.
Well, I was able to resonate with many of the comments you shared, actually just from conversations I've had with patients today. So, that's
exactly.
Yeah, absolutely very common. So for clinicians who haven't reviewed these guidelines just yet, can you walk us through what are the most significant changes from prior guidelines?
Yeah, so the big take-home message is we now have 2 level A recommendations. And level A recommendations here mean that you must offer. So this is pretty bold language. And in the 2016 guideline, there were no level A recommendations. So we're really hitting it hard, and we've come with 2. So the first one is IV prochlorperazine. So that is a must offer, of course, with the caveat that it should be a patient who it's appropriate. You're not worried about any major contraindications. You don't think there's a high risk of them having tardive dyskinesia, extrapyramidal symptoms and whatnot. The other one that now also has level A for recommendation is greater occipital nerve blocks. And again, with the caveat that you want to choose it for the appropriate patient, and the patient needs to be comfortable with the fact that they're going to get injections in their head. But these are now both options that must be offered to patients. So that's a really exciting update. Prochlorperazine was in the 2016 guidelines, but it was a level B. So it's now been upgraded to a level A, and the inclusion of greater occipital nerve blocks, that's completely brand new. The other big update is that before opioids were in the guideline, and the recommendation was to not offer them, but it's now been, I guess you would say, downgraded to a level A must not offer, specifically for hydromorphone. That's because of a study that was a class 1 study that had been done since the 2016 guideline, where hydromorphone and prochlorperazine were compared. And prochlorperazine very clearly beat out hydromorphone. And adding in that we know that hydromorphone and other opioids come with significant risks, including, ongoing use can increase medication overuse. We know that there's higher risk of addiction. And we know that just in general, patients don't tend to do as well. They're more likely to come back and need more treatment, not achieve headache freedom. And so we are able to say that we really shouldn't be offering this. Obviously, this is not, as someone recently said to me, a guideline. I really liked that line, so I'm stealing it. There are going to be cases where it could be appropriate. And we did put the caveat that there may be appropriate patients, but it should be someone where you're not worried about addiction, not worried about medication overuse, headache. They're not on really high amounts of opioids where you're worried about causing, overdose or side effects. They've previously had opioids, and you know that they have a good response with good tolerability. So again, it needs to be done very thoughtfully if you are going to use them.
So those are a lot of big changes that you just outlined.
Okay.
I think it's very helpful for the treating clinician and also very patient focused as well. And I think will hopefully allow the clinician to have conversations with patients about why these changes are important and hopefully allow them the best possible care. I want to switch the topic a little bit because we know that patients with migraine go to the ER for different reasons. Sometimes it might be an attack that just has not responded to what they have at home. Sometimes it might be an attack that's been going on for a couple of days. Sometimes it might be definition for status migrainosis. Sometimes it might be a recurrent attack. And sometimes it might be a refractory migraine. Do the guidelines address these different scenarios a little bit? And can you speak to that in a little bit more detail as well?
Yeah, unfortunately, they don't speak to it as much as I wish they did, because these are some of the things I hold near and dear to my heart. Status migrainosis, refractory migraine; those are my babies. And I think what's important to know is that the studies that we're looking at, the majority of them were done in the emergency room, but even some of the studies included, if they were parenteral treatments, they were allowed to have been done on an outpatient basis. So first off, some of the studies actually got downgraded in terms of how we did our recommendation if the population studied wasn't representative of the emergency room. So that's part one, where really our focus was headache being treated in the emergency room where it was diagnosed as migraine. That might include patients who had, any of the possibilities that you just mentioned, but none of the studies were specifically focused on those populations. For instance, we don't have a randomized control trial for status migrainosis. So while you can use these to apply to status migrainosis, it's with the knowledge that the guidelines are for a migraine attack in general where they've ended up in the emergency room, but not specifically for status migrainosis, even though I'm sure some of the studies did include those patients. Refractory migraine, we really don't have great data on what to do for them acutely, and less likely that any of them were really included in these studies, but it's always possible. But in terms of recurrent attacks and an attack that didn't respond to something at home, my guess is that was a good portion of the patients, but that data was often not well captured. And of interest, a lot of these studies don't actually tell us how long the attacks have been going on by the time the patients were seen. Often they don't include data about what they've already used or treated at home. So did they use all of their home treatments and it didn't work? Or is this someone who they don't have any good home treatments? And this is really what they're getting first for an attack that was particularly bad. So there's a lot more that we could do in these studies in the future to really try to capture who specifically is the population being studied. So a lot of that stuff is less well known than we'd like.
That's very, very helpful. Do you anticipate any barriers that ER teams might face as they try to implement these guidelines, and how can we help overcome any of those challenges?
Yeah, I think in headache, we are very good about getting good quality studies. We have great consensus statements and guidelines out there. One thing that we don't tend to do a lot of is implementation science, and there's actually a lot that could be done there. But it's a really complex field. Our default is to say that we need to make sure that they're trained. And that might be true for some of the physicians and the APPs in the emergency room where perhaps they don't know how to do an occipital nerve block. But they're often doing a lot of nerve blocks and they're very comfortable with procedures. And that's likely not the only barrier that's missing. So when you look at implementation science, there's actually a whole I guess you could call it a whole strategy or a whole approach that people use called ERIC, and it's got 73 different strategies in different clusters. And it looks at everything from not just how you educate, but also, do you have the right stakeholders? Have you identified champions in headache and in emergency med who can really help guide and promote this change? Have you involved patients and their families? Do they want this procedure? Are they increasing that demand? Have you gotten the media involved? Have you gotten advocacy groups involved? How is the infrastructure going to change? Do emergency room doctors have enough time to feel like they can do this procedure as opposed to just quickly put it in order, say, for prochlorperazine? Are they getting reimbursed enough that it's worth their time? Are insurance companies going to cover this? So there's so many different aspects that we need to really address to help make sure that our guidelines really bring science to the bedside.
As we think about the most important people in the room, our patients, how do you hope that these guidelines will change or hopefully improve their experience the next time a patient goes to the ER with a migraine attack?
The most important thing in my mind is that we're really inconsistent with what patients get. And I would love to see that, especially for a patient where they're naive to treatments and we don't know what works for them, that they're offered the things that we at least have the best evidence available. So if a patient comes in with a migraine attack, they've never been treated with anything in the emergency room, or they're not sure what they've had in the past, that they're then offered something that we have level A. So either they're said, they're given prochlorperazine or greater occipital nerve blocks as the potential next step. Now, whether or not you start to add in some other options and do combined therapy, that's a whole area that we need more research. But for instance, from the 2016 guidelines, we know that there's level B evidence for using dexamethasone to prevent recurrence of the migraine attack. So perhaps that might be something that would get added into the mix. Would you bring in some of the other level B medications, like some of the NSAIDs, like ketorolac, for instance, and add that into the mix? We now also have level B evidence for supraorbital nerve blocks. Let's say they've got a lot of frontal pain. Do we want to add that on top of the greater occipital nerve block? So considerations like that, but doing it thoughtfully with the science to back it up and help guide why we're selecting these treatments. And then also, veering away from saying that, the patient got a migraine cocktail. That doesn't tell me what the patient got. It doesn't tell me what I should do in the future. I really want to know the patient got, this level A treatment combined with perhaps this level B treatment, or they didn't get this level A treatment, but it's because they tried it in the past and didn't respond, or I felt that they were at high risk of having a side effect because they're already on, say, a daily neuroleptic, and so I didn't want to add that on top of it. So having that sort of thoughtful decision and ultimately hoping that we can try to build our EMRs so that there's even these sort of flows to how you would make these decisions to help clinicians when they're busy and they need that, touch of the finger help. So that's what I'd love to see, is this more consistent medicine offered to patients, because that's going to hopefully lead to better quality of care and hence better results for them, more headache freedom, less likely to be bouncing back to the emergency room.
I love their vision. Well, you shared that, these guidelines are updated every few years. You and your team have been able to address some of the gaps of the last iteration of these guidelines. As you look forward, what are some of the remaining gaps that you hope that the next iteration of these ER guidelines will hopefully address?
I think that's a really great question. I'll kind of give a couple different answers. So part one is I want us to do a better job of how we do the studies in the emergency room. I want future studies to have, better sample sizes. Unfortunately, the tools that were used in the 2016 study, it doesn't actually downgrade a study for low sample size, or for not being the optimal population, or for not using the optimal time point. So I think we need to start to set expectations of, if you're doing a study on migraine in the emergency room, just like we have guidelines for how you do an acute treatment trial, just like you have guidelines for how you do a preventive treatment trial. Here's how you should do a treatment trial in the emergency room for migraine. We need to have consistent endpoints. What people chose to use as the endpoint was all over the map. I think we need to use something standardized, especially for parenteral treatments, like 1 hour, which is something that's mentioned in the acute guidelines, where 2 hours is the typical endpoint, but 1 hour was mentioned as a consideration for parenteral treatments. I think that would be a more appropriate standard. And making sure that we've chosen what should be looked at 1 hour. Is it, the change in headache, and what is the rating scale that we're using? And, are we looking at headache freedom, headache relief? Are we looking at most bothersome symptoms? Because that's almost never captured in these. And is it relevant in this patient population? We don't even know that. So that's one part, is we need to have better consistent data, and better baseline data needs to be picked up. Is this a patient who has chronic or episodic migraine? How long was this attack? Often it's just time to, from treatment to response, but did they come in 2 hours into their headache? Did they come in 2 days, 2 weeks? That's really relevant data, because then we can also start to address things like status migrainosus. So all of that stuff needs to be mentioned, as well as what did they actually take at home? Is this a patient who is not responding to home treatment, or is this an untreated or incompletely treated attack? Those are also really important differences for which patient we're studying. The next piece is, that combination treatment I talked about. Is using prochlorperazine, good enough, or should it be prochlorperazine plus dexamethasone plus ketorolac? How do we actually start to build what we classically talked about as this migraine cocktail? What is that combo of fusion that is optimal? So I think we need to start to have better studies around that. And then the final piece I kind of alluded to in part one is I'd really like us to study status migrainosus. Obviously, that's a huge bias for me, but I think we also need new standards of what the expectation there is. Because how do you study a patient who they often contact me that same day or the next day when their treatments haven't worked. And to enroll them, we'd have to say, well, we got to wait till you've been 72 hours. And so right now we don't have a good way to study these patients unless you're just kind of catching them on treat several days in. So we need to come up with a plan of how we study these patients so we can actually start to have some randomized control trials on how to treat specifically these patients. Because likely a huge proportion of the people in the emergency room are patients with status migrainosis, but as I mentioned in part 2, we don't know that because that data is not captured, and we don't have any studies on that specific group. And I mean, obviously, I can go and list a million other dreams, but I think those are good 3 dreams right now, right?
Oh yeah, absolutely. And hopefully by the time we're ready to update these again, we'll have the trials we need to answer those really important questions.
Fingers crossed.
Yeah. Well, thank you so much for taking the time to speak with me today, and thank you and your co-authors for the immense work you put into creating these guidelines, which will help so many people who live with migraine every single day.
Thank you very much. It was definitely a labor of love, and I know we were all very relieved to get it done and very pleased that we have, this to kind of offer to the community and our patients to help guide treatment.